Thank you. And is my screen visible and am I audible?
Yeah, Dr. Oni, it's visible and you're audible clearly.
So that was a very brilliant presentation by Dr. Sujoy, and congrats for the wonderful work that he has shown. My task today is to discuss the clinical implications of thyroid autoimmunity. And I wrote this when we founded the Thyroid Journal many years back in 2004, that the sheer magnificence of thyroid diseases in India coexists with ground realities such as patient affordability and accessibility. So this will be my brief agenda for today, my talk. I will start with introductory aspects, go on to a case which I will call the H factor, and another case which I say the mother and son don't agree in thyroid function test. So these are the various anti-thyroid antibodies. You have the anti-TSH receptor antibody, the anti-TPO antibody, and the anti-thyroglobulin antibody. Interestingly, the anti-TSH receptor antibody is located extracellularly, anti-TPO is intracellular, and anti-thyroglobulin antibody is intrafollicular with low levels in the blood circulation. The access of the immune cells to this antigen in the case of anti-TSH receptor antibody is without tissue destruction, but in anti-TPO antibody, it is after thyrocyte destruction. The duration of antigen exposure is short for the TSH receptor antibody and longer for the others. The type of antibody, the class is mainly IgG1 for all the three. In the neonate, transplacental passage can occur for all the three antibodies. Important to note that all these antibodies are seen in autoimmune thyroid disease. 90%, you will see that TSH receptor antibodies are present in 90% of people with Graves' disease and 10% of Hashimoto's. And TPO antibodies are seen in more than 80% with Graves' disease as well as Hashimoto's. Importantly, anti-TG antibodies have very little clinical role now, except in the follow-up of thyroid cancer, where a thyroglobulin and an anti-thyroglobulin antibody are both measured in the same sample. The extrathyroidal targets, which I'll come to in a moment, and action in breast cancer progression. Well, people have suggested that TPO and anti-TG antibodies may have protective effects, but we don't know. If you look at the extrathyroidal effects of anti-thyroid antibodies, the TSH receptor antibodies may be associated with Graves' orbitopathy, Graves' dermopathy, and some cancers. TPO antibodies are associated with Hashimoto's encephalitis. Well, there is a controversy on whether this entity exists per se, but you can also find it in cases of infertility, in vasculoplacental complications, and of course, in certain cancers, especially survival of breast cancer patients. Anti-TG antibodies also are seen in infertility, certain cancers, and survival breast cancer patients. What do the data from India suggest? So this is the paper I published in 2013, which was a study of 5,376 people from 8 cities in India, where we looked at the prevalence of subclinical hypothyroidism, hyperthyroidism, and anti-TPO antibodies. We found that subclinical hypothyroidism was commoner in women. Of course, the p-value was significant, but I want to bring to your attention the anti-TPO antibodies. The prevalence was about 16.8% in men and 26% in women, showing you that women had a higher chance of anti-TPO antibody positivity. And women were also, in our study, more likely to be detected with hypothyroidism compared to men, the odds ratio being 3.36. And women in the age group of 46 to 54, that age group had the highest occurrence of anti-TPO antibodies. So having looked at that, I'm going to discuss 2 cases. Now, some of these cases aren't embellished with evidence-based medicine, have got some ingredients for waking up the audience on a Sunday afternoon, So I'm indulging myself a little bit and also indulging all the participants here. So the first H factor, if you thought that it was H for Hashimoto's, well, it's not, it could be that also, wait till the end, but H factor here, I'm talking about the Hürthle cells, which are really eosinophilic cells, granular cytoplasm with a vesicular nucleus and a large nucleolus. So what's with the H factor? So this is a 53-year-old lady with thyroid swelling for 5 years and for evaluation. This is an FNAC request, and all the clinical details written were 53-year-old lady, thyroid swelling for 5 years. Now, I know that this meeting is also attended by several people from the laboratory, and most people who work in the laboratory, pathologists, microbiologists, are all aware that writing good clinical details is important. So let's see what happened to this 53-year-old lady, thyroid swelling, sent for an FNAC request. And this is what the pathologist might like to talk to the doctor. So this is an imagined conversation based on a real phone call. Well, when this happened, those days, mobile phones weren't there. And this is just from my memory. So the pathologist messages and says hi. The clinician says hi. The pathologist asks, are there any more clinical details? The clinician said, already sent, thyroid swelling, so many years. Does the patient have Hashimoto's thyroiditis? Yep. TPO antibody positive 5 years ago. So there is Hashimoto's thyroiditis. Is the patient taking thyroxine? Yes, for hypothyroidism. Is there a diffuse firm goiter? Yes. So therefore, the pathologist says, okay, may have atypia of unknown significance rather than Hürthle cell neoplasm. Okay, thanks, it's so here is a conversation where all these details could have been given by the clinician to the laboratory person. Instead of writing thyroid swelling for 5 years, it's good to note down that there was Hashimoto's thyroiditis, TPO antibodies were positive, patient was on thyroxine, hypothyroidism was diagnosed, and there was a diffuse firm goiter. All this would have saved valuable time and helped the pathologist to make a good diagnosis, because Hürthle cells vary with their size and shape. And also, Hürthle cells can show a lot of various changes, as in this paper, in Hashimoto's thyroiditis. So seeing Hürthle cells does not necessarily mean Hürthle cell neoplasm, but or even Hürthle cells as part of a thyroid, some other neoplasm of the thyroid, but it might just mean Hashimoto's thyroiditis. So let us write as many clinical findings as we can to help the pathologist to help the patient. And of course, thyroid ultrasound scans can help the pathologist even report better. So the H factor also stands for Hikaru Hashimoto. I wrote this as an ode to Hikaru Hashimoto in 2014, who's incidentally, in May, Hashimoto's day also falls. So interesting thing about Hikaru Hashimoto is that for a very short period of time, he was in the limelight for thyroid. He wrote his paper on lymphomatous in the thyroid gland, and it was about 30 pages long. He moved to Germany to study. And when the First World War came, Hashimoto had to suddenly return to Japan. He returned to his home. He began his family practice and soon. So from a clinician researcher, he went to an international researcher, came back to his home, not literally his house, but he came back to his home in the sense that he came back to his practice as a doctor, as a family doctor, and started working as a family practitioner in his hometown or home village. He even made home calls, and it is in one of those house calls that Hashimoto went to visit a patient at home, and he himself developed that infection. Probably it was enteric fever, we don't know. He succumbed to that infection, a story which rings a lot of bells even today in this era of the pandemic which we are in. My second case is called Mother and Son Don't Agree in Thyroid Function Tests. And maybe Professor Maxim may not be aware of this, but this is a very famous Indian movie called Mother India. And I've taken 3 pictures from Mother India here. One is a picture of this very famous actress, Nargis Dutt, with a gun. She looks really as if she wants to go and accomplish something. And then in the picture in the middle, she's got two children. It looks as if it's winter. The skin is dry. I don't want to comment too much about the picture. And the third picture, you will see that in the neck, there is a suspicion of a goiter there. So, well, this has nothing to do with the case I'm presenting, but as I said, it's a Sunday afternoon, and I thought that let me indulge myself a little bit. But this was a 26-year-old lady who came to me several years back, and this was her first pregnancy. She was in the 7th month of her pregnancy, and she came with very classical features of thyrotoxicosis. The free T4 was 2.8, and the TSH was 0.0001. So clearly thyrotoxic. The TSH receptor antibody was positive. I treated with antithyroid drugs and managed the situation uneventfully. So indications for TSH receptor antibody testing in pregnancy are ideal time is about 22 weeks. There is present or past Graves' disease. If there is high TSH receptor antibody, if there's a history of a previous neonate with Graves' disease. Well, I was really surprised to see the baby when the baby was born. Remember, the mother had high T4, low TSH, thyrotoxicosis, TSH receptor antibody positive, and I treated with antithyroid drugs. But the baby, when the baby was born, the baby had hypothyroidism. So the baby's TSH was 28 and the free T4 was low. The baby did not have a goiter. The TSH receptor antibody of the baby was positive. I treated the baby with levothyroxine. So the mother had TSH receptor antibody positive hyperthyroidism, and the baby had TSH receptor antibody positive hypothyroidism. And I treated the baby with levothyroxine, reduced the dose, and I was able to stop it over 4 to 5 months. And eventually, at the end of 4 or 5 months, the baby's TSH receptor antibody became negative. Let's look at what could have happened. Now, the TSH receptor antibody has an N-terminal and a C-terminal. The N-terminal stimulates. So the TSH receptor antibody, the N-terminal epitope actually stimulates, and the antibody against the C-terminal suppresses. So though there is a TSH receptor antibody, some antibodies directed against some epitopes will stimulate the thyroid gland, some will suppress the thyroid gland, and this stimulating antibodies can also later on be replaced by suppressing antibodies. And the TSH receptor antibody titer that we measure in the lab does not differentiate, at least need not always differentiate between a stimulating and a suppressing or blocking antibody. So possibilities in this patient are that the mother had TSH receptor antibody mediated hyperthyroidism, but those antibodies became blocking antibodies and they got transferred to the neonate, and the neonate developed TSH receptor antibody mediated hypothyroidism because of the transplacental spread of the TSH receptor blocking antibodies from the mother to the baby. It's also possible that the baby had hypothyroidism as a chance effect, because hypothyroidism, congenital hypothyroidism, very common in India. It could also be that in those days, this patient was treated with propyl thiouracil. It is possible that propyl thiouracil crossed the placenta and had caused fetal hypothyroidism. But remember, this baby did not have a goiter, so that was an unlikely scenario. The fourth possibility is that giving propyl thiouracil to the mother as an antithyroid drug may have induced maternal hypothyroxemia, and that hypothyroxemia may have caused fetal thyroid hormone deficiency. But remember, the fetal thyroid gland develops after 3 months. So this was the 7th or 8th month. So the fetal has a thyroid by then. So the likely possibility is the transplacental, transfer of the maternal TSH receptor blocking antibodies to the baby, which would have blocked the baby's thyroid from working and caused fetal hypothyroidism. And as you know, these antibodies, IgG antibodies, remain for 3 months and go away. They went away. So coming back, this is the last slide where I explained this slide, which was not really evidence-based. I just want to highlight that in the first picture of this movie, Mother India, Nargis Dutt, if you are diagnosed hyperthyroidism, you would not have been mistaken. The second picture, if you see, if you looked at hypothyroidism, you would not be mistaken, because indeed there is a dramatic difference in the appearance of the two pictures of the mother. And of course, I don't want to comment on the Bollywood stars who are acting as the children. But in the third picture, you can see a goiter. And those of you who've seen Mother India movie, there is a scene in which Mother India, this Nargis Dutt as a lady, there's no food in the house. So she goes to the back of the house and she takes out some tubers and roots and takes it and cooks and gives it to the children. And well, I'm just imagining, if you like, to break it for some light thinking, that maybe it's possible that those tubers and roots could have contained goitrogens. We know that cassava can cause goiter. So could this have predisposed to the appearance of goitrogenesis in this picture? Well, that's a story for another day, and that's very speculative. And I'm just, as I said, indulging myself a little bit. So I've looked at the introductory aspect, looked at the 3 antibodies, talked about the H factor. I did discuss all the 3 antibodies used in clinical practice, and I ended with a couple of cases which may have piqued your clinical interest. And once more, it's a pleasure being with all of you here. And thank you, everybody, for listening to